Dr. Foster, whom we heard yesterday already, would now take us on the overall principle of management of patients with uveitis. And this will set up the theme for how we manage patients with different stages of the disease. Dr. Foster, welcome again. Dr. Foster, you may need to unmute, I think.
Am I muted now?
Now we can hear you, Dr. Foster.
Okay.
Can you, oh, wait a minute.
And we see your slide too. Perfect.
Can you see the slides? Yeah.
Yes, thank you, Mr. Foster.
Yes.
Very good. Good to be back. My task for this morning is to talk about my philosophies of treating patients with ocular inflammatory disease, steroids, biologics, and immunomodulatory agents. I'm having a little trouble advancing the slide, so I'm wondering if someone there can help me. There we go. So we want to abolish active inflammation. Without that, slowly but surely, vision is going to be damaged. As sure as you're alive, you wait long enough, vision's going to be damaged. Adequate therapy reduces the likelihood that that will happen. So how can we modify the poor prognosis in patients with uveitis? First and foremost is to eliminate all active inflammation. Do whatever it takes to put out the fire. Appropriate antimicrobial therapy, limited tolerance for topical or systemic corticosteroids, and that leads then to the idea of early implementation of steroid-sparing immunomodulatory therapy. So this is the algorithm that I use in treating patients with ocular inflammatory disease. Aggressive steroids initially, with cycloplegia, put out the fire, use steroids in any way you have to accomplish that goal, even using general anesthesia to give periocular steroid injection if need be. I will often try an oral non-steroidal anti-inflammatory drug as well, especially in patients with B27 associated uveitis. And my favorite is naproxen because of its limited effect on the cardiovascular system. And brief, and by brief I mean three months or less, steroid therapy, topical and systemic corticosteroid therapy. And then it's time to move along to immunomodulatory therapy. One may need to involve surgery in the care of the patient with ocular inflammatory disease, but you'd like to try to get the eye quiet before that time comes. Now, I have taught on this matter for a very, very long time. I've written articles, I've published book chapters, and still not much has changed. Still, everybody and his cousin is using steroids chronically to treat uveitis. Why would that be? Why is making change so difficult? Well, first question to ask is it really so hard? Who says so? Well, ask anyone who's been trying to lose weight, somebody who's addicted to work or drugs or alcohol. These gentlemen produced a trans-theoretical model and described 5 stages in making change. And what is this? Well, this is what the patients at the Mass Eye and Ear Infirmary looked like with pemphigoid when I first joined the faculty there. Dr. Dolman had tried for years to lead the charge in making change, but change wasn't happening, and patients were ending up looking like this or like that. Pemphigoid was blinding hundreds of patients because change wasn't happening. Patients were being treated with steroids, whereas they could have been treated with cyclophosphamide or another immunosuppressive agent and gone from looking like this before the cornea was involved to looking like that in remission. Pemphigoid is a curable disease. I don't know of any person these days who treats patients with cicatricial pemphigoid with chronic steroid therapy. They know that it's curable. What about birdshot? Is birdshot curable? Al Vitelli and I showed back in 1994 that it is. Al was a fellow with me at that time, and we published on our results of cyclosporin therapy in treating birdshot. And we went forward then with another publication some years later on 49 patients, and we found that there was a big delay in patients getting referred to us for chemotherapy for their birdshot. Why would that be? Well, here's an example of why that would be. A reviewer of the paper that we submitted said that there was a lack of evidence to state that this technique of immunomodulatory therapy can represent a startup therapy for birdshot. I was promoting the idea of using 2 drugs at that time rather than 1 to reduce the risk of side effects. And so I wanted to say this to the reviewer. Of course, I didn't. What I said was this: the reviewer is absolutely incorrect in his or her belief that employment of 2 separate drugs is more risky, more dangerous than employment of monotherapy. The increased safety and effectiveness of 2 complementary drug strategy is well proven and is exactly the reason why transplant surgeons employ that model always in order to prevent transplant rejection, kidney transplant rejection, for example. 2 separate pathways to control the immune system, 2 separate possible side effect profiles, a lower dose of each drug compared to what would be required with monotherapy. The conclusions seem to put steroids as a marginal part of therapy, which is not exactly correct. My response to that statement from the reviewer too was, actually, this is exactly the point we're trying to make. Corticosteroids represent a very poor choice in care of patients with birdshot and should categorically be marginalized in the long-term care of patients with this chronic disease. Uveitis, including birdshot, is curable in many instances. Change happens slowly, not in a smooth way, but with jagged spurts. How many psychiatrists do you think it takes to change a light bulb? Well, it only takes 1, but the light bulb has to want to change. And so it is in patients with inflammatory diseases of the eye. Many of them are curable. There are a few that I cannot cure, but most of them are curable. Long-term durable remission of all drugs. You don't have to keep them on drug for life. The immune system has the capacity to relearn, to be reset. It can, given the opportunity for peace and quiet from its aberrant, inappropriate responses for a sustained period, learn to behave correctly and not to participate in autoimmune behavior after medication controlling has been stopped. So this is the preferred practice pattern that I've published on in the past for caring for patients with ocular inflammatory disease. Do whatever it takes to induce remission, whatever medication it takes, without steroids. Pursue steroid-free remission in all instances. Then keep the patient on that drug or drugs that have accomplished that goal of steroid-free remission for at least 2 years. After the patient's been in remission for 2 years, slowly taper the drugs and achieve drug-free remission, i.e. cure. I've used the cancer therapy model, and I keep the patients in drug-free remission for at least 5 years before I say that they are in fact cured. This goal of curing people with ocular inflammatory disease is categorically possible, and we've shown that it's possible in patients with pemphigoid, with rheumatoid scleritis, with birdshot, with serpiginous, multifocal choroiditis, with panuveitis and JI-associated uveitis, parsonitis, and other chronic recurrent vision-robbing inflammatory problems. Pursue cure. If each of you remembers that cure is possible and do the things that I'm saying to do in order to accomplish that goal, you will reduce the burden of blindness secondary to uveitis. So, what do I do? Well, first of all, I try to understand the general mechanism, if not the outright diagnosis, of what the problem is. Harvest tissue whenever possible, and then do whatever it takes to stop the inflammation. Saving the patient's life is paramount, and saving the patient's vision is almost always possible. Now, as it turns out, some diseases require specific immunomodulatory therapy. For example, granulomatosis with polyangiitis requires cyclophosphamide or rituximab. No other drugs that I know of can cure GPA. With atopic keratoconjunctivitis, it's a calcineurin inhibitor that is required to accomplish cure, cyclosporin or tacrolimus. I often will use methotrexate in patients with other types of ocular inflammatory disease because it's so easy. Once a week dosing, and they're done. It can be usually given by oral administration, but sometimes it requires intraocular or subcutaneous administration. I do use folic acid in my methotrexate patients on the other 6 days of the week when they're not taking their methotrexate. Azathioprine has to be taken twice a day. So too is Cellcept or mycophenolate mofetil and cyclosporin. All of these drugs have potential complications, potential side effects, and so one has to feel comfortable managing the patient. Oftentimes, eye doctors don't feel comfortable, and so they partner with a chemotherapist, a rheumatologist, or other chemotherapist. The alkylating drugs like chlorambucil and cyclophosphamide are the most dangerous of the drugs that I use. They have to be used in a particular way. They have to be used in such a way that one is affecting the bone marrow. If you're not affecting the bone marrow with the alkylating drugs, you're not going to cure the patient. With chlorambucil, I shoot, and with cyclophosphamide, I shoot for a target white count, peripheral white count of 3,000 to 4,000. If you can accomplish that, and then hold it that way, juggling the dose around and keeping the white count down at that level for a year, the likelihood is extremely high that you will have cured the patient and can pull away from the alkylating drug. With Humira or adalimumab, we treat with subcutaneous injection every 14 days first, and then we will try to go down to every 7 days if the patient's having some breakthrough inflammation. With infliximab, 10 milligrams per kilogram body weight per month is the target that I use, and we treat for 2 weeks, loading, and then every 2 months. With Actemra or tocilizumab, I go straight to 8 milligrams per kilo every 4 weeks. I do not use anything less than that. Beautifully tolerated, very nicely tolerated drug, and highly effective in many instances. With Rituxan, I use it differently than the rheumatologists do for rheumatoid, or the hematologists do for the things that they treat patients with Rituxan. The dosing is the same, but I give it much more frequently. So 375 milligrams per square meter body area weekly times 8, and then monthly, open-ended. Interferon alpha, 9 million units, subcutaneous 3 times a week, and IVIG 2 grams, not 2 milligrams, but 2 grams per kilogram body weight monthly. That's a lot of protein, and it cannot be given all at once. I have to split that amount of protein out into 3 separate sessions. So Monday, Wednesday, Friday, 2 grams per kilo, and they're done for the month. So in summary, the standard of care in somebody with uveitis, the preferred practice pattern in such patients is appropriate evaluation, making sure you're not dealing with a masquerade. Put the fire out to prevent damage to the retina. Beware of masquerades like cancer, and cure infection. Limit corticosteroid use. By all means, limit the amount of steroids that are being used. Do not get into the habit of being comfortable just keeping the patient on steroid on and on and on. You'll produce cataract, you may produce glaucoma. And of course, we want to limit drug side effects, bone and eye, and bone marrow as well. So that's all I have for that subject matter. I'm happy to take questions if people have questions about how I take care of my patients with uveitis or other forms of ocular inflammatory disease.
Colleague, if you have any questions, either you write or you ask Dr. Foster directly. So, Dr. Foster, in general now, how long do you think that we should treat the patient with, let's say, with birdshot? What would be a mean number of month or year that you would treat to give you the best opportunity to reach remission? So in other words, when we discuss with the patient, if he or she asks, how long do you think I need to be on this regimen? So you would say that we would like to make sure we monitor you with various things, make sure things do not progress. But usually, how long do you think we will be able to tell the patient on an average that you would need?
If I'm not using an alkylating drug, without alkylating drugs, I've got a 1-year time limit. And the reason for that is to prevent malignancy and prevent sterility. They can typically stay on alkylating drugs for a year without running into that problem. But for all the other drugs, I like to keep them quiet with no steroids involved in the picture for 2 years before I start trying to taper medication.
So that's a very good number, because that's exactly what I'm also doing. So I usually tell the patient that it's between 18 to 24 months that we'll be doing. So that definitely is correct. For the alkylating agents, I'm using them. I'm a little bit shy, so I'm still using them initially, just posting them, like in the case of necrotizing scleritis, for example. I'm posting them with just monthly IV cyclophosphamide, and then change to other IMT or keep them on other IMT shortly, because I found them a little bit less of a problematic with side effects compared to, let's say, oral cyclophosphamide.
Right, and it's curious to me, IV pulse therapy with Cytoxan is safer. It's not more risky than oral cyclophosphamide. Oral cyclophosphamide is more risky with hemorrhagic cystitis being the primary thing that can crop up in those patients. So pulse IV therapy is less risky, but it's also less effective. It's less curative.
That definitely is correct too. So yes, that would be there. Any other comments from other colleagues before Dr. Foster go into the next discussion, which is on uveitic glaucoma? So one of our colleagues from Canada asked whether or not, he asked you that in your practice, Dr. Foster, do you usually have a rheumatologist in-house to help with dosing and blood work, or do you prescribe and manage the IMT yourself?
So I am a member of the American College of Rheumatology. I'm one of 2 eye doctors in North America who is, in addition to being an ophthalmologist, also a member of American College of Rheumatology. So I'm quite comfortable, and I've been doing it for nearly 50 years now, managing these cases on my own. In many, many instances, in the majority of instances, eye doctors are not comfortable doing that, so they're well advised to partner with a rheumatologist.
Yes, and I saw the message our colleagues that either way is fine, but I think the message that Dr. Foster wanted to share with us is that please do not be afraid, and please don't consider this a poison, which is oftentimes I have been told that I poison people and so on. So please don't be afraid. As long as you use it properly, it's actually safer than steroid, and many of us have learned that. So the other question to you is that what dictate the preference between adalimumab and methotrexate? Let's say for JIA.
Well, you know, it's FDA approved. Adalimumab is FDA approved for treating uveitis, and that's one argument for moving along to it first. I like methotrexate a lot. It's got an 85 to 90 year track record of safety and effectiveness, and it's easy to use. It's once a week dosing. So I'm flexible. I can go either way with those 2 drugs.
And great. And the other question we have is, do you taper alkylating agent after 1 year? So I think from what you described, Dr. Foster, usually we like to limit alkylating agent to just 1 year and not more, because even if you use at the lower dose more than 1 year, like you mentioned, the risk of side effect increased significantly. So we try to just use alkylating agent within a year only. Is that your recommendation as well?
That's correct.
Okay, wonderful. So let's. This is an important question. So one of the colleagues asked whether or not you involve patients in your choice of IMT. In other words, do you discuss with the patient why you select XYZ for him or her? I think the answer is yes, but I want to hear your thought, because I think that absolutely a must.
Sometimes if my hair is not on fire and I've got, I don't have 100 patients waiting to be seen, yes, sometimes we do that.
Yes. Okay, so this is great. So now we can move to your second part of the lecture, Dr. Foster, on uveitic glaucoma.
Thank you very much. There's some special challenges involved in treating patients who have uveitis plus elevated intraocular pressure. One is the fact that there is inflammation present, and one needs to deal with that. And the way to deal with that usually is with corticosteroids first. And of course, corticosteroids can aggravate the glaucoma. Many of the patients are young. I'm thinking now of the JIA patients, and they've already got some damage, so there's less reserve in the eye. There may be some vasculopathy and decreased blood flow, and some of the patients may actually have a steroid response with respect to the pressure response to steroids. And some of the tools that we have in the toolkit for treating glaucoma are not wise to be used in patients with uveitis, Salitan and pilocarpine, for example.
Pastor, do you have your slide up?
I do. You can't see them?
No, please kindly hit the share screen again like we did yesterday. Let's see.
Can you see that?
Not yet. I think it's at the bottom of the screen, and you move your mouse and it's a green button that says share screen.
Is that slide being shown now for you?
No.
It's a title slide, uveitic glaucoma.
No.
Dr. Foster, on your screen, do you have up the Zoom window right now?
Let me look.
Because the share screen button where we'll be able to see your slides is going to be on the Zoom window, not on your PowerPoint window.
Would I need to go to the share screen?
Yes. The green button that says share screen.
Got it.
Will let you choose your PowerPoint.
And now I need to find the PowerPoint presentation.
No, you first the PowerPoint presentation you have, you already opened it, so that's fine. Now you just go to the Zoom and you hit the share screen.
Well, I'm a little lost here, folks.
That's okay, Dr. Foster. What do you see on your screen?
Right now, I see the people who are logged in.
Okay, perfect. So if you take your mouse down to the bottom underneath of the blocks with names in them, do you see the buttons where it says participants, Q&A, polls, chat, and share screen?
Yes.
Okay, can you click the share screen button for me?
I've done that now.
Okay, and it brought up a window with different tiles in it. Are you seeing that?
Yes.
Okay, is your PowerPoint one of those tiles?
No.
Okay, so what I would recommend doing, do you see the first tile? It should say either like desktop or screen one.
I see.
Click that one and then click share.
Down here, bottom again.
The share button should be a blue button on the right hand bottom corner of the window with all the tiles.
Okay, now I've got my talk directly in front of me now.
It's still not showing for us. I think, what's it saying when you are clicking the blue share button on the Zoom screen? After you hit the green button that says share screen, and then you choose which screen you want, and then you hit the blue button that says share.
I'm sorry, folks, I'm lost.
That's okay. Let me see if I can grab your slides really quick.
Yep. So my wife just came in, and she may be able to help me too.
Okay, perfect.
Trying to get the glaucoma talk up.
So you have them open, that's it, right?
Yeah.
Where's your Zoom? Where's the glaucoma talk again? Here?
There.
That's it. That's it.
Perfect.
Yes.
Can you see it now?
Yes, we're
Yeah.
seeing it.
Perfect.
Good?
Thank you, Francis. Okay, so uveitic glaucoma affects a large number of patients who have uveitis, up to 30%, and in JIA it's even higher. So the JIA population is the one that will be emphasized in this talk. How do you reduce the likelihood that it's going to be a problem? Well, number one is getting the uveitis under control. Whether it's postoperative or recurrent uveitis, they need to get under control. Both of those will sabotage drug therapy or filtering surgery success. The key to long-term prevention is control of the inflammation. The surgical care of patients with glaucoma in the context of uveitis has a troubled history. One of my former fellows, who eventually went to practice in England, did a study in England, and she found that a very high proportion of her patients with uveitic glaucoma were successful with their glaucoma surgery. And why was that? Well, it was because she had them on immunosuppressive chemotherapy, and the filters were working, and so forth and so on. Other groups have tried to replicate that, but without using antimetabolites, and without using systemic antimetabolites. They were using topical antimetabolites, and the outcomes were quite poor. Now, Dr. Peter Netland, who used to be with me at the Mass Eye and Ear Infirmary here in Boston, taught me how to do the things I'm going to tell you about now, including Ahmed valve implantation. And we studied 21 eyes of 19 patients who had uveitic glaucoma. Their systemic immunomodulatory therapy was in place, and their inflammation was wonderfully in control. There were 11 women, the rest were male. The follow-up was substantial, 3 years or so, and they had a variety of underlying causes for their uveitis. JIA was the most common. Pre-op, all had high pressure, and post-op, all were beautifully controlled. The mean reduction in IOP was 25 millimeters of mercury, highly statistically significant, and visual acuity was maintained in everyone, and 43% had improved acuity because of concomitant cataract and or vitrectomy surgery. The average glaucoma medicines that they were requiring before surgery was substantially reduced, as you can see here, and 67% of the patients were on no pressure reducing medications at all. We expanded that study a few years later, Dr. Netland and I did, looking at 60 patients, 69 eyes, with average follow-up of 30 months, and with similar outcomes. Pre-op pressures were high, pre-op meds were high, 2/3 of the patients had prior surgery. 20% of them had prior glaucoma surgery. And we did a number of things. About 39% of our patients had additional surgery, not just the glaucoma operation, but also cataract extraction or vitrectomy. And these patients also did well. The number of meds that were required drastically reduced. Almost 40% of the patients weren't requiring any drops at all, any meds at all, for pressure control. Now, this wasn't long-term totally successful. You'll notice that there was a drop-off. As the years went by, we had some patients come out of control. So by 7 years, 25% of our patients were not in control with respect to the glaucoma. Complications were not numerous. Some patients had valve failures and had to have the valve replaced. 8 patients had some corneal edema. 6 patients had hypotony. 1 patient had a retinal detachment. And 1 patient had a tube exposure. What about non-penetrating surgery? It's got a dismal history. A number of researchers have tried that, and they found almost no success in their patients who had viscocanalostomy. Success rate by Obrart and team at 1.5 years, 64%. So uveitic glaucoma is an important, difficult to treat additional vision robbing problem in patients with uveitis. Medical therapy is often insufficient. Filtration surgery has a checkered record with late failures common. Recurrent inflammation contributes to filter failure. I would suggest that no one entertain the idea of doing a filter on a glaucoma uveitic patient without having that patient on systemic immunomodulatory therapy. My favorite valve is the Ahmed valve. It has some advantages to conventional filtering surgery. Control of inflammation is absolutely the key by preventing uveitis recurrence, which is critical for enhancing the likelihood that the glaucoma surgery is going to be successful. Well, thank you all very much. I'm happy to entertain questions that you might have now on uveitic glaucoma.
So, therefore, Dr. Foster, then would you then propose that a device or either tube or a valve be the primary type of treatment right at the beginning when we know that medical therapy doesn't work anymore, or we recognize it?
Yeah, we do whatever it takes to preserve the nerve. Sometimes something as simple as SLT laser therapy will take care of the problem. It is not provocative, by the way, with respect to uveitis. We do have to watch the patients carefully, but I don't find that SLT laser therapy for uveitic glaucoma is a problem.
Any colleague, if you have questions, please write it down or ask Dr. Foster directly. Dr. Foster, what about in this era, we learned a lot about this expression and many of the simpler glaucoma surgical procedure. Have you seen any of them working well for uveitic glaucoma, or have you tried any of them?
I've done some of the express shunts, and more often than not, the patient does need another procedure like a tube eventually.
The other aspect is that thinking about some of the newer information about what we know about uveitic glaucoma and some of the cytokine and things, have you attempt to treat them with particular cytokine, like for example, certain interleukin blocker and things like that, or certain type of factor, knowing some of the study that have shown the eye fluid of eye with certain type of glaucoma to show certain type of perhaps inciting factor?
I'm sorry, Quan, are you asking about cyclodestructive procedures?
No, I'm thinking about, for example, the study has shown that ocular fluid of eye with uveitic glaucoma may show different type of cytokines or various factor. Now, knowing with that, would we consider specifically targeting those things when, let's say, you have a patient that's already have a tube shunt in or something, or so the maximal medical therapy, and we still are not able to fully control the pressure yet?
I have no experience with looking at the cytokines in patients with uveitic glaucoma.
Now, can you also comment on, so oftentimes the management of ocular hypertension in uveitis is tricky because it's either due to the disease itself or at times often due to the use of steroid. And obviously we go beyond systemic steroids, so at times it's due to either topical or one of the long-acting steroid implant. Please comment on those and see at what point you would say, let's put in let's say a fluocinolone implant or fluocinolone insert, but at the same time, we know we need to control the disease, but we know that the pressure may rise, so I'm also going to do let's say, glaucoma procedure at the same time.
A complicated question, and I didn't stay with you the whole time.
So, the question would be, when you choose, let's say, a steroid device, either a implant like a Radisert or an insert like a Uveitic, and you need to put them in the eye, on the occasion where you also will move forward and just go ahead and place a valve or a tube as well?
I'm sorry, Quan, I'm not following you.
So let's say you have to put in a Radisert in the eye, okay, let's say birdshot, and for whatever reason, the patient cannot tolerate systemic. And so we have data that show placement of Radisert, the fluocinolone implant in the eye. That is very high rate, as we know, of ocular hypertension and glaucoma. Do you ever do a combined procedure that put the Radisert in at the same time, place like a armored valve or something at the same time with that?
Yes, I think that would be reasonable.
And how do you just at what point you would consider using such a device like a steroid implant for that, and not using systemic? In other words, I think with the trick here is to balance the side effect of the steroid implant with the pressure problem, with the glaucoma problem, and other side effects.
I'm going to have to beg off on the question.
Okay. I think the concern we have with our colleague here is that sometimes we have to come up with that decision, and we try to make the best out of it and present to the patient, okay, these are some of the potential side effects of systemic therapy. These are some of the potential side effects of local therapy, and we put them together and let the patient participate and choose what they think might be best. And so, and we know for certain device will definitely lead to problem with the pressure, So there have been situations where we end up doing both procedure, place the implant, and at the same time place a treatment for the glaucoma, especially in patients who already maybe have lost the other eye to uveitic glaucoma, for example. And that. Any additional comments to Dr. Foster or anything else I want to discuss about treatment? Maybe, Dr. Foster, since we have a few more minutes in here, you can discuss with us about family planning when you, and also, so two things, one on family planning, and two, perhaps the implication from the site study for which you were a major contributor, and using them as a way to share with this colleague how about the safety of IMT.
The safety of what?
Of the immunomodulatory therapy, because certainly you were a major contributor to the site study that John Kempin and you and others have done with that. So can you relate it to that to discuss with our young colleague here that we indeed have very good factor about good data to show the safety of this agent?
Yeah, I guess I've been considered a sort of a pioneer in the area of systemic immunomodulatory therapy, and my patients represented by far the majority of the patients in that site study. It was a collection of 5 separate investigators, and the numbers that I contributed was far greater than anyone else who participated. So I think that says a lot about my philosophy. I'm not shy about using systemic drugs to prevail over the inflammatory problem that's going to kill the eye. It has to be done carefully and with limitations, but I'm a big proponent of systemic non-steroid immunomodulatory therapy in the care of patients with ocular inflammatory disease.
Yes, so for our younger colleague in the audience there, the SITE study, SITE, Systemic Immunomodulatory Therapy study, is very much a major proof of what Dr. Foster has proposed. So in other words, prior to that study, Dr. Foster has been using that type of treatment for decades. But then the question has always been, when patients are being put on IMT, are they more susceptible to infections, to malignancy, to other type of morbidity or mortality? So the SITE study was in a way, a retrospective data study where 5 major ophthalmic centers in the United States shared data on the patients who have been treated with immunomodulatory therapy or IMT, and that you just heard. So indeed, the practice from Dr. Foster at the Massachusetts Eye and Ear Infirmary contribute the most number of it because he has been using it for the longest and probably most extensively compared to the other 4 centers. So therefore, a lot of data from there. And that data has now been published extensively, and it's basically looking at it gives you the overall result, but then it's break into different agents. For example, azathioprine, mycophenolate, methotrexate, because then each subset have that. And all of those studies have shown that when using those medication properly, one does not have any increased risk of malignancy or infections compared to typical situation. So it definitely very strong. But the data also show, as we expected, that if you are to use the alkylating agent and for a certain long period of time, then indeed you do increase the risk of that, which is what's suspect. But the size study very much help to confirm what had been shown. So when you use this properly, this agent properly, it's actually relatively safe to do. And you have heard from Dr. Foster how he monitored this patient, and some of you have seen in my own clinic as well too. So this is, when we use this type of agent, a type of thing, we need to monitor the patient very closely. And so blood evaluation, as Dr. Foster mentioned, every 6 to 8 weeks, which is what you see I'm doing as well too. So we need to monitor this patient. We cannot rely on other. If you are the one who prescribed them, you need to make sure that they are being followed, and so that they don't have side effects unexpectedly. The side effects are rare, but you definitely don't want to experience them for the patient. Dr. Foster, you want to add anything else to that aspect?
No, not really. I think that you've done nicely in summarizing. I will tell you that the fellows that I train will often notice as the months go by that nothing's happening to anybody. They're all safe and well, and occasionally a fellow will say, gee, I don't know why we are looking at the blood counts so often. They're all doing well. And then lo and behold, here come by somebody with a hematocrit that's had the bottom drop out of it. And I'll say, well, that's why.
Yeah, I think it's very, very critical that we don't deviate from this type of monitoring, because when we are using our patient, when we are treating our patient, we want to make sure that we provide the best possible care for them. So therefore, we should not deviate. And so during your seeing them, make sure that you check for that and don't let go of that. So if you don't have that, if you don't have the lab work for, let's say, 6 months or so, which is very long, and definitely like a year, the patient for whatever reason forgot it, please don't prescribe that. You'd rather just have it done right away so that you see, because the last thing you want is to have the patient get into a complication. And it happened with some of the one that you least expect to, because I have seen situations like this happen several times with mycophenolate, which is one of the very safe drug, but still, when you see this, you don't want to miss with this aspect from there. And in addition to the blood count and the liver function, if you're using other things, for example, like the alkylating agent, then of course the urinalysis and other things are also important as well. So know your drugs, and then also follow that, and don't deviate, because the time that you deviate is when we create and you experience problem with that. And so, okay, great. Anything else from there? Any other comments from everyone?
I see a question in the Q&A, Dr. Nguyen.
Okay. The question is, let me see, which question do I see now?
If you click in the Q&A portal.
Yes, I see that. Well, I'm seeing which question we have not answered, because we have answered quite a number.
We answered this one?
Yeah, I believe so. The one that's not answered for that. And I think that the other thing that we learned about this as we manage our patients is that we also need to be persistent and have patience. Yes, when we present a lecture like this, we give talk like this, seem to be very straightforward. You would like to have intravenous immunoglobulin to use, or if you want to use XYZ, you want to use infliximab, or you want to use rituximab or tocilizumab. Yes, it's not too difficult once you understand them and you write them. But what we like to say is that you also need to be persistent and fight for your patient too, because most of the time, the insurance company may not approve this type of request because they say, well, why don't you use steroid first? Or in some cases, although much rarer because adalimumab is also quite expensive, why don't you use Humira for something? But less so with Humira because it is an expensive drug. So you have to be prepared to know enough about the disease, the data to show that it may be working with certain type of drugs and things in order to fight. Because oftentimes you will get back a message from the insurance that they will reject it and they won't approve it. So many times you need to get on the phone and talk to them. First, they may talk to your technician, then they talk to the nurse in the clinic to help, then they talk to the fellow who helped you with the case. But at times you yourself have to, then you really believe in it, you have to go and fight for your patient and get on with it. And you discover that the other person, on the other hand, may not really understand medicine for first place or even and definitely not ophthalmology. So you have to escalate and demand that the discussion be moved up to the higher level. Because if you really believe, for example, and you saw there, a patient with some disease would definitely, let's say a patient with Uveitic disease, for example, it would need a certain type of treatment for BES, and you want to fight for that because you believe in that, then you have to really go out and make sure you discuss with the insurance company. Dr. Foster, what is your experience in this, and do you have any trick that you can share how you convince the colleague at the insurer to do?
Oh, I never, ever, ever have a problem. They know not to mess with Stephen Foster.
Yes.
No, I'm always very, very gentle and receptive and kind to the people who are calling to maybe obstruct giving approval for a patient to be on mycophenolate mofetil or some other drug. I find that 9 times out of 10, they'll just roll over and give me what I want.
That's great. I mean, that if your name is Steve Foster, if your name is like Juan Wen or someone else, then you need to be a little bit nicer and convince them. Lend me more time to discuss about this thing, because definitely I have gone through with that, and but it eventually will work. And what I have learned also is that you should get the patient to call the patient representative office of some of this company, because when the patient call, let's say when a mother call for a child, it's very effective, and they can get a lot of things done like that with that. Dr. Foster, we have one last question here, and the question here has to do with intravenous immunoglobulin. So in your experience, what is IVIG best for? When do you think that the patient should definitely receive IVIG? In what condition?
IVIG is unusual. We still to this day don't understand exactly how it is immunomodulatory, as opposed to just reconstituting the immune system in people who don't have a B cell compartment of their immune system. It was theorized just on the basis of a researcher thinking about it decades ago, that IVIG could actually be immunomodulatory. He had never treated anyone. He'd never done any experiments on it, but he theorized it. And it turns out that he was right. And so the first autoimmune disease that it was used, and still is today, was idiopathic thrombocytopenic purpura. And after it was shown to be effective for ITP, other autoimmune diseases were treated with IVIG. And it's unusual in that it cannot be used in the usual way that one would think that one's going to use IVIG for reconstitution. It must be used at very high dose, 2 grams per kilogram body weight every month. And that can't be done safely. That has to be split up, at least into thirds. So Monday, Wednesday, Friday, a patient gets 1/3, 1/3, and 1/3 of their monthly IG that they're going to get for their autoimmune disease. And infusion centers hate that. That chair time is chair time that they're not making. You know, they make their money typically with the first hour of infusion, and all the rest of it is pennies. So they hate the patients who are having to sit in that chair on 3 separate days to get their immunoglobulin. But to try to push it is a mistake. Debilitating headache is extremely common if they push it. And fluid overload is a second potential problem. So we sometimes get into friendly arguments with the people in the infusion centers about allowing the patients to stick around and take their time in getting the IG.
So I love forgiveness. So I used in general for autoimmune retinopathy. So that's one indication that I try to treat some of that if they see any signal. The other one would be for ocular cicatricial pemphigoid, OCP, which I use some as well. Are there any other particular ophthalmic condition, inflammatory condition that you think that we should try IVIG earlier rather than later?
Yeah, it's remarkably effective. It's not like penicillin for pneumococcal pneumonia, but it is very effective for a number of autoimmune ocular inflammatory diseases. And if a patient, so I don't go to it quickly, but if a patient's got a stubborn problem, I will not shy away from it because of the expense and the tedium of actually receiving it. The autoimmune retinopathy that you mentioned is one of the things that I've worked on for many years now, and I've come up with a recipe for treating AIR that is outrageously expensive. It includes IVIG plus Velcade, plus rituximab. So you think about those 3 drugs being used every month on patients with AIR, and you're talking about vast amounts of money being spent on these people. But of all the things that I've tried over the years for treating patients with AIR, that is my most successful recipe. And so that's what I go to immediately. I don't bother with any of the conventional chemotherapies. I don't bother at all with just IVIG. It's got to be the 3-drug recipe. You see, plasma cells, which are, after all, the end-stage cell that's pumping out antibody, are not killed with IVIG or with Rituxan. Velcade is what kills plasma cells. Plasma cell cancers are treated with Velcade. And so using that recipe of Rituxan plus IVIG plus Velcade is my current, well, and has been for 5 years, my favorite recipe for treating AIR.
And again, for that regimen, so the way that you manage patient with rituximab in that particular, again, you do them weekly for 8 weeks and then monthly still throughout that regimen?
That's right.
Okay. And how-
which is also unusual, of course. And I mean, rheumatologists act like I've set their hair on fire when they hear that recommendation, because they're not using it that aggressively. But we found through the years that that's what it takes for autoimmune diseases of the eye. Weekly times 8 and then monthly.
And then for your Velcade, do you use it at the regular dosing, or do you use that in any particular regimen? The Velcade, Dr. Foster, the second agent, do you use it with the regular recommended dose, or do you use it at higher dose?
No, regular, and it's a particular protocol that I use. I think what we're doing is 6 days of the week getting the Velcade, and the 7th day they're on holiday.
Okay.
My wife Frances is in charge of that. I don't know that I've told you just now the exact way that she's doing it, but
Yes.
Pretty close.
Thank you. I think we're learning something every time we talk to you. Okay, so this is great. Yes. Okay. So that is the aspect from there. Okay. So the one of our colleagues asked, are there good textbooks to learn about IMT? So I can answer this one. So that's easy. The Dr. Foster have a book called Uveitis. I think it's at the back of my one of the book in the back of my shelf right there is Uveitis. Is by Foster, and the second author is Al Vitale, Vitale. It's called Uveitis, and I think there's a subtitle, Principle or something. But basically, if you look at that, that's the book that have in it. It's a very heavy book, a big book, but in it, it has many different disease entity, and under each entity, we discuss carefully the use of different agent. And then there's several chapters in the beginning that go into the principle. Dr. Foster, when was the last edition of that book? I forgot now. I know I contributed to, but I wasn't sure. Your last Uveitis textbook was on. Are you updating it, or was the last one like 2 years or something ago?
I'm very old. I'm 78 years old, and I'm tired.
Okay. So we will take it on just like the Ryan read now. So we make sure that book will move forward too. Okay. Okay. So we will get that thing done. But Michael, is yeah, that's the textbook in there. The late Dr. Nessenblatt also wrote a book, but it's less comprehensive than the one because we have all of them here and that little bit. But if you go to the latest version of Dr. Foster textbook is big, but it has a lot of all the information in there. And as you just heard, we will have to make sure that that book is moving forward with the next edition at some point in that part there. Okay, let me see what else there. Okay, I think that is it. I think Dr. David Chu is coming up next. Is that right, Brianna?
Yes, Chu is up next, and he is logged in.
Okay.
I'll prompt him to unmute himself so he can share a screen.
No problem. Dr. Foster, thank you very much. And if you can, please join us again.